Okay, great. Okay, so should we start?
Yeah, let's go for it. Okay, so today we have Dr. Jessica Hellings giving us a talk. And before we get started, I'll just provide some Zoom procedures. So we ask that everybody remain muted during the presentation, but you feel free to leave your video on. And if you have questions, you can either send them in the chat at any time and I can pose them at the end of the talk, or feel free to unmute yourself at the end and ask your questions directly. Let's see, you can find a complete schedule of the semester's talks on our KCART website, as well as video of our past talks. Next week, or our next talk, which is next month, is Corinne Neal. And so a little bit about Dr. Jessica Hellings. She has her master's in medicine in psychiatry at Witwatersrand, a university in Johannesburg, South Africa. And she did her fellowship in child and adolescent psychiatry at KU Med. And she's currently a professor of psychiatry at UMKC and is a board certified psychiatrist affiliated with Truman Medical Center in Lakewood. Dr. Hellings has 30 years experience in psychopharmacology and the medication treatments for severe challenging behaviors in children, adolescents, and adults with autism spectrum disorder and intellectual and developmental disabilities, including aggression, self-injury, and property destruction. And she includes minimally verbal individuals and treatment resistance in her studies. She also studies gut-brain axis in neuropsychiatric illness, women's advocacy, and medical education development to increase focus on autism and IDD. Her current research focuses also on new and old drug impacting BDNF for neuropsychiatric illness associated with severe challenging behaviors in all ages with ASD and or IDD. Let's see. Dr. Hellings has served as medical director of ASD and IDD neuropsychiatric services for KU Med, the Ohio State University, and the Neisinger Center in the state of Missouri. And today her talk will be focused on amitriptyline for restricted and repetitive behaviors in ASD. Thanks so much for being here.
Thanks so much. Thank you, Maggie, and thanks, Dr. Mosconi. As you heard, KU is my alma mater, so it's great to be back with everybody. And I'm not sure if Dr. Warren is on, but he was one of my mentors.
I'm right here. I'm right here watching you.
Well, there's Steve. Nice to see you.
Yeah, nice to see you as well.
Right, and I have to mention my mentor, my late mentor, Steve Schroeder, who was just such a great mentor through the years, for over 20 years. And the wonderful thing about Steve Schroeder was, whenever you came up with an idea, no matter how bad it was, he would always say, "That's a great idea, just do it." So, you know, you can't beat a mentor like that, because you go there full of enthusiasm and then you come back with even more. So, but anyway, thanks so much for being here. So I'm just going to do a quick walk through restricted and repetitive behaviors and the use of amitriptyline in autism spectrum disorders. So I don't have any disclosures at the moment. And I've had some previous affiliations for studies. So we're going to identify the approach to autism spectrum disorder and how to diagnose comorbid neuropsychiatric disorders. And we're also going to focus on executive function and restricted and repetitive behaviors, which are they're part of the core features of autism, and especially difficult to treat. And then we're going to describe the treatment use of amitriptyline in pediatrics and in autism spectrum disorders, including safety strategies. And then we'll discuss the upcoming controlled trial of amitriptyline for restricted and repetitive behaviors in children and adolescents with ASD. Okay, so what are the criteria for autism spectrum disorder? At this stage, I'm sure I'm preaching to the choir, but I can't tell you how many senior faculty psychiatrists have told me they actually need to find out what this is all about, that they actually have no idea, which is quite troubling in academia. But it's persistent deficits in social communication and social interaction across multiple contexts, currently or by history. So that includes social, emotional reciprocity, back and forth conversations, and it's hard for them to initiate or respond to social interactions. Deficits in nonverbal communication, lack of facial expressions and nonverbal communication. And then deficits in developing, maintaining, and understanding relationships. So, you know, we were always told sort of crudely, you know, they're in their own world kind of thing. So, and then part B of the diagnostic criteria are the restricted and repetitive patterns of behavior, interests or activities as manifest by at least two of the following, currently or by history. So if you're talking about by history, up to age 6 years old is like the critical part, early development. So stereotyped or repetitive motor movements, use of objects or speech, motor stereotypies, lining up toys, echoing, and using odd phrases like "don't throw the dog off the balcony." So I think that was in one of Leo Kanner's first descriptions of a boy with autism. The little boy was on vacation with his mother, and they had a dog and they had a balcony, and he kept trying to throw the dog off the balcony. And so his mom kept telling him, "don't throw the dog off the balcony." And then that idiosyncratic phrase got stuck in his brain, and years later he would say to people, "don't throw the dog off the balcony," which there was no dog and no balcony. And so that's where I think part of the overlap could become with people misdiagnosing schizophrenia. So misdiagnosing that as psychosis or hallucinations. Insistence on sameness, so inflexible adherence to routines, ritualized patterns of verbal or nonverbal behavior, distress with small changes, rigid greeting rituals, need to take the same route or eat the same food every day. So I had a patient who wanted his mother to reply 100 times every night to him, "good night." And if she varied her tone or she seemed to get impatient with him, they had to start all over again. And it ended up with quite a lot of violence and aggression towards his mother. And then highly restricted fixated interests that are abnormal intensity and focus. For example, what car do you drive? So various different folks that I've met with autism would stop at the end or even during the visit and say, what car do you drive? Where's it parked? What color is it? But the most difficult one that I had was a boy who he loved the sound of crying babies. And so he would have a little tape recorder whenever he went with his mother to the mall, and he would record crying babies at the mall. And then when he came to my visit, he wanted to hear the recording of crying babies during the visit with me, which was very difficult. And then hyper or hyporeactivity to sensory input or unusual sensory interest, for example, smelling or touching things. So they might actually come over and smell your hair, you know, which is not really socially acceptable, but once you get used to it, that's okay. So examples of restricted and repetitive behaviors, they're also known as interfering behaviors somewhat in psychiatry. So rocking back and forth, flapping hands, spinning, or twirling, spinning wheels, staring at fans or spinning objects and washing machines, twirling ribbon or string, pulling on threads to destroy clothes or shoes or mattresses, rewinding short clips of a movie and watching that, lining up toys in certain patterns, shaking sticks or flipping things to open and close over and over. So there are literally over 100 of these possible ones. So what are the reasons for repetitive behaviors? So that's what we're going to talk about. So superficially, they might look like they're due to excitement or elation or dealing with overwhelming emotions. They may be due to anxiety or a communication of mental or emotional states. They may help focus their concentration. So for example, somebody sitting studying might be tapping their leg or foot. The same behavior may serve different purposes at different times, depending on the situation and one individual can have different behaviors for different things. Okay, so I wanted to just pull in the older definition of what we used to call pervasive developmental disorders, which in DSM-4TR was called pervasive developmental disorders, but autism spectrum disorders are definitely more clear for parents to understand. So autistic disorder was the more severe form. So they had to meet all of the criteria. PDD, NOS, pervasive developmental disorder not otherwise specified, was sub-threshold for diagnostic criteria. So really, I think it could have been called minor autism or sub-threshold autism. And then Asperger disorder, Asperger disorder was normal language development, but with the social impairments and the restricted interests, repetitive behaviors. So an example of that would be Greta Thunberg, who openly says that she has Asperger's, but she is extremely bright and she is doing good things for the world. So, but people with Asperger disorder were really unhappy when they were going to be lumped together with everybody else on the spectrum for DSM-5. So I was part of the DSM-5 field trials about that. Okay, so Rett syndrome is no longer a major criterion or subcategory, but it can be used as a specifier. They have stereotyped hand washing or hand wringing and progressive spasticity and childhood disintegrative disorder, but those are now specifiers. But it just shows you that the DSM-4TR was somewhat more descriptive as to what to expect if somebody had a certain label. But one of the reasons they were all lumped together in autism spectrum disorders was it was found that there was no real difference in behavioral outcomes, in functioning in community and that kind of thing. So, okay, so then I thought we'd just talk a minute about DSM-5 intellectual developmental disorder, because so many people with autism spectrum disorders have this, but it is quite different. Somebody without autism spectrum disorders does look quite different to somebody with it. So impairments in general mental abilities that impact adaptive functioning. So it's more like global deficits. So the person is more like cognitively dulled or slow. They don't have those necessarily those repetitive behaviors and restricted interests. So the conceptual domain is affected. So reading, writing, math, language, and memory skills. Social domain, social judgment, empathy, and some social communication skills are impaired. And then a practical domain, personal care, job responsibilities, money management. So they usually don't have those repetitive behaviors unless they have obsessive compulsive disorder. So DSM-5 attention deficit hyperactivity disorder criteria. So I thought we would throw this definition in as well while we're at it, since so many people with restricted and repetitive behaviors also have ADHD. So the inattentive type of ADHD is a diminished focus, careless mistakes, distractible, forgetful, and failing to complete things. And interestingly, the inattentive type is thought to be more common than the hyperactive impulsive type in people with developmental disabilities. But the hyperactive impulsive type is the one that gets people into trouble, and it makes it more difficult for them to integrate in the classroom and in the community. So they are hyperactive, fidgety, and restless, on the go, out of seat, and over talkative. And they're impulsive. It's hard to wait their turn. They interrupt, blurt out answers. And then I added some more behavior descriptions, which I think would really help if the DSM had them in. So for example, hitting, kicking, cussing, talking back, biting, pinching, eloping, stealing things, and affective impulsivity of laughing and crying. So that is where people often get misdiagnosed as bipolar disorder, because they can't put the brakes on their mood. Okay, and so ADHD is classified into combined or predominantly inattentive or predominantly hyperactive impulsive. So most of the ones that come to us in psychiatry are combined. So now we'll just quickly run through what are executive functions. So these are your cognitive control processes that monitor your own behavior, and they help you to attain goals. So this is your internal control of behavior. So the three main ones here are in bold: proficiency in adaptable thinking and mental flexibility, so that if things change on the spur of the moment, then you can think, okay, now I need to do this. So that's, in my opinion, is like switching gears. Can you switch gears when you have to? Then planning and self-monitoring and self-control, the ability to inhibit impulses or put brakes on your behavior. So that's another big key problem in aggression and in people with developmental disabilities. So working memory is like, okay, I remember last time I did this and I got into huge trouble and I should not do this again. And then time management and organization. So executive functions are really key to self-control. So we'll talk for a minute about ASD and ADHD and their executive function deficits, because there's some important studies that have been done. So the ASD plus ADHD group seems to share impairment in both flexibility and planning, in common with the ASD only group. So they are rigid and they cannot switch gears. And then the ADHD and ASD group shares response inhibition deficit with the ADHD group only. So that's where the impulsive aggression comes. For example, their brakes are not working. And that happens as well on their affect, on their mood. Like they'll be laughing like crazy and then they'll be crying, and then they'll be misdiagnosed as bipolar. And they often also become suicidal under pressure, and they're not able to put their brakes on suicidality as well. So referred to as a cognitive endophenotype in neurodevelopmental disorders. And findings are based on a review of 26 studies of executive function comparing ASD and or ADHD in children. That was by Craig and co-workers in 2016. So what is the psychopathology that results from executive function impairments in people with ADHD and ASD. So they have difficulty controlling emotions or impulses, problems with starting or organizing or planning and completing tasks, impaired listening or paying attention, short-term memory issues, inability to multitask or balance tasks, and socially inappropriate behavior. So it really impacts a lot of things that a person needs to do to succeed in school and in life. So looking at hyperactivity and impulsivity, these two behavioral domains are important since they correlate with aggression and self-injury. It's basically a shared cognitive correlate of impaired behavioral inhibition. But the important thing, as already described by Burbridge and co-workers in 2010, is that they also correlate with restricted and repetitive behaviors. So it's a type of motor impulsivity, again, conceptualized as due to impaired inhibition. So executive function deficits linked to restricted and repetitive behaviors were studied by Iverson and Lewis. In 2021, they published a study of 3 correlational meta-analyses and examined the strengths of association between RRB levels and performance on set shifting, inhibitory control, and parental report-based EF batteries. So their gears and brakes are impaired, to put it crudely. That was their finding. So they found a significant association between high RRB levels and poor executive function skills. Interestingly, these associations are also common in typical development. For example, toddlers may jump up and down, flap their hands, and have tantrums. And future studies, they said, should create interventions that aim to improve these skills. So our talk last week was actually about an intervention trying to improve these skills, notably focus. So this follows on to that. So etiology and pathogenesis. So key brain areas for information processing are impaired. Processing of attention, distraction, executive functions, and affect regulation is impaired. Key regions for this include your frontal cortex, prefrontal cortex, amygdala, and cerebellum. And genetic and epigenetic factors are important in this. So what are the genetic and developmental factors? So several candidate genes code for central dopaminergic pathways. Prenatal nicotine exposure in the presence of dopamine gene polymorphisms may contribute to ASD and or ADHD in the offspring. And the genetic inheritance of ADHD is strong. However, in GWAS studies, genome-wide association studies, hundreds of markers with low effect size were found linking ADHD, ASD, schizophrenia, and epilepsy to one another. So there was an interesting imaging study of an inhibition task in ASD versus ADHD versus typically developing. They studied inhibition-related neural correlates using fMRI during an inhibition stop signal task. So children aged 8 to 12 years, and there were very stringent inclusion and exclusion criteria. 18 children with ADHD combined, 13 with ASD, of which 9 also had ADHD, and 14 typically developing children. And they found distinct brain activation in different areas between the two groups. And that was published by Sans et al. Last year. Okay, so distinct brain activation patterns were in autism spectrum disorder, the right frontal regions were activated. And in ADHD, it was the right inferior parietal regions that were activated. So they found that the two disorders recruit different regions of the brain to achieve behavioral inhibition. So a very difficult study to accomplish, but a very interesting outcome. So let's talk more about repetitive behaviors in overactivity and motor impulsivity. So RRBs are associated more with ADHD domains in subjects of all RD levels. They have compromised behavioral inhibition associated with impulsivity and hyperactivity. And then the Burbridge study was in 2010 that they developed something called the activity questionnaire, and they had subscales of overactivity, impulsivity, and impulsive speech. And they compared the scores on 755 individuals with intellectual and developmental disability with scores on the repetitive behavior subscale in 136 participants with varying levels of RD. And a common cognitive impairment, they decided in inhibition, may underlie both impulsivity and RRBs. Okay, so why would we want to even treat RRBs pharmacologically? So especially if they've not responded to, or the family is unwilling to try behavioral treatment. So these are interfering behaviors. They interfere with learning and special services like OT, PT, speech, and social activities. And they can be disruptive at home and in the classroom and jeopardize placement. So they can cause self-injury or aggression if stopped, or property destruction. For example, my adolescent patient, he would literally destroy his clothes and his jeans and his shoes and his mattress by pulling the threads, and then also breaking the law. So they may enter homes. I've had one or two patients that would enter strangers' homes to look for women's dirty underwear. But no medications, unfortunately, have been shown to have efficacy for restricted and repetitive behaviors so far. So why would we be wanting to use tricyclic antidepressants in children and adolescents? So amitriptyline is a tricyclic antidepressant. It's one of the first antidepressants from the 1950s, the early 1950s. The tricyclics were actually designed as antipsychotics, and it was found in drug studies that they didn't work as antipsychotics, but they certainly helped patients who were depressed. And so they were shifted over into a class of antidepressants. So imipramine is FDA approved for bedwetting or enuresis from age 6 years old. So imipramine is a sister drug of amitriptyline. And amitriptyline, interestingly, is commonly used in pediatric patients for functional abdominal pain. Also, it's a very good analgesic used for chronic pain and also for migraine headaches. So tricyclics are also the second most potent line of treatment for ADHD after stimulants. And dizipramine was used and studied in ADHD. There's a Cochrane review of tricyclic antidepressants that showed that they were essentially safe, although they could cause changes in blood pressure and pulse, but overall safe. So what are the actions of tricyclic antidepressants? So they're known as dirty drugs. They're like clozapine. If any of you've heard of clozapine, it's like the cannonballs of antipsychotics. It's so potent as an antipsychotic, but it's also an old dirty drug. But tricyclic antidepressants inhibit serotonin and norepinephrine reuptake, and they antagonize NMDA and methyl D-aspartic acid. They inhibit sodium and calcium channels. They antagonize kappa and delta opioid receptors. They have potent analgesic effects. They have anti-inflammatory activity via the prostaglandins and TNF-alpha modulation. And then amitriptyline has potent neurotrophic effects in animal studies via TrkA and TrkB agonism. So this remains to be shown in humans. So, but there have been studies at NIH studying amitriptyline for Alzheimer's dementia, interestingly. So amitriptyline and fluoxetine induced alterations in gut microbiota in rats exposed to chronic, unpredictable, mild stress. Okay, so, but what are the side effects of tricyclic antidepressants? So the most common side effect is dry mouth. The good thing is that when I use amitriptyline, I'm using low doses. So side effects are generally rare. So urinary retention, constipation, blurred vision, that's when you're getting to higher doses. Then you do get a rapid heartbeat. You can get an increase or decrease in blood pressure, but it's not usually anything serious. But if a person takes an overdose of a tricyclic, they can die from this torsade du poids, which is it's a ventricular type of a ventricular tachycardia. But we do monitor the QTC. That's an interval on the electrocardiogram that tells you what your risk is of getting an arrhythmia. So as long as your QTC is under 440, you're good. And over 500 is when your risk for torsade becomes more significant. So we definitely want to keep the QTC less than 500, but most of the time we are operating in 440 or less domain. So activation, excitement, and irritability can be a side effect. And then neuroleptic malignant syndrome, extrapyramidal side effects, psychosis, suicidal ideation. So lots of things to watch out for. But as I said, we're using low doses, generally speaking, and knock on wood, we've had very good luck with it. So what about tricyclic studies in autism spectrum disorders? So C.T. Gordon and co-workers in 1993 did a 10-week double-blind crossover comparison of clomipramine and placebo using 12 subjects in each of 2 groups. So clomipramine versus placebo in the first 12 subjects, and then another 12 completed clomipramine versus desipramine. So clomipramine was more effective than desipramine or placebo for autism symptoms, including stereotypies, ritualized compulsive behaviors, and anger, whereas both clomipramine and desipramine improved hyperactivity more than placebo. So interestingly, I've had patients come to me on clomipramine who are having problems, and then when I substitute amitriptyline for the clomipramine, they do much better. So that's an interesting caveat. But in any case, so we published in 2013 a 50-patient child and adolescent chart review of amitriptyline for ADHD primarily, but it also helped other behaviors in children and adolescents with ASD. The mean age was 9.4 years. The age range was 4.6 to 17.9. The mean dose was 1.3 milligrams per kilo per day. And the dose range was 75 to 100 milligrams daily. The maximum dose that the FDA recommends for bedwetting is 2.5 milligrams of imipramine per day. So that's approximately double what our mean dose was in this chart review series. The mean duration was 3.4 years, so they were on it for a long time. Doses divided to minimize side effects. So we divided into morning, 4 p.m. and bedtime. And then the mean trough blood level was 114.1. So the nice thing about amitriptyline is that you can measure your blood levels and see whether to go up or down or stay where you are. So you can see if it's in a therapeutic range. So the therapeutic range for depression is 100 to 250. So we were at the very bottom of what is known as the depression range. Okay, so more stuff about the chart review. So we would not prescribe amitriptyline for chaotic settings, like a chaotic home with 5 children and the mom's leaving the medication out on the kitchen counter. So we would not do that. And also assess overdose risk in family or patient. Has anybody in the family taken an overdose? And anybody had major depression or become suicidal? So we would not put it in that kind of home. And then EKG is checked at baseline, as I said, to make sure that the QTC is less than 440. And then we would keep checking EKGs about quarterly. And trough blood levels are measured after the dose increase and quarterly if possible. I have had some folks that it was impossible to measure blood levels, but they were not in this chart series. But as long as you keep your dose low, you're usually good. So some responders had levels reported as undetectable. So likely the depression therapeutic range is higher than it is for autism spectrum disorder. Okay, so if tolerated, amitriptyline was found to benefit ADHD, but also insomnia, anxiety, aggression, self-injury, bedwetting, and eating behaviors. So interestingly, what I think is that amitriptyline probably works on executive functions as in ADHD. And so through that, my observation is that it clinically helps restricted and repetitive behaviors and OCD, but studies are needed, obviously. So it's used with stimulants and antipsychotics in that chart review, lots of other medications, most often risperidone or aripiprazole and anti-seizure medications. So it's important to watch for drug interactions, especially with selective serotonin reuptake inhibitors that inhibit cytochrome P452D6. So you would taper those off first before you try to use amitriptyline. So managing drug safety and overdose toxicity. So select responsible parents and patients, as we said, to prescribe a tricyclic for no previous overdoses or suicidality. I did have a mom who told me she phoned back after I prescribed amitriptyline for her child, and she phoned me back and said, I forgot to tell you, my husband previously took an overdose. So we changed to a different medication. So, but be vigilant for possible drug interactions. The parent must agree to keep all medications locked away, for example, in a lockbox, and discuss overdose toxicity clearly and document that this was done. Remind the parent at each visit, document, and there are also online brochures available that would really be useful for the parents of any patient taking medications. And then minors and individuals in group living don't usually self-administer their medications as a rule, so they don't have access to medications. So really, if you're talking about adults, that's 90% of the adults that you're treating. But not to say that drug safety is not a central focus. So the randomized trials that have been done in autism spectrum disorders are few and far between. So methylphenidate was studied for ADHD in children. It was found to be half as tolerable and with twice as many side effects, and half as effective as in typically developing children. And atomoxetine was studied. I was part of that study when I was in Ohio, and it is effective. And interestingly, I've also had quite good luck clinically with it in adults, including adults that are minimally verbal and lower functioning. So, but there was a good multi-site study of atomoxetine for ADHD, which was found to be effective. And then guanfacine has been studied in smaller studies also for ADHD. Melatonin prolonged release has been studied for sleep. It's not actually available in America. Risperidone and aripiprazole have been extensively studied for irritability in youth. Selective serotonin reuptake inhibitors, interestingly, they had negative results for Celexa or citalopram and 2 negative Prozac or fluoxetine studies in youth with ASD targeting repetitive behaviors. So that's where the executive function idea comes into it, and the fact that amitriptyline might help repetitive behaviors based on its ability to alter cognitive processes, but that remains to be shown. So oxytocin, interestingly, has been studied for about a decade, but there was a large multi-site randomized control trial just published in the New England Journal of Medicine that there was no difference from placebo, that no significant difference from placebo in this big multi-site study. So as I said, the SSRI studies are mostly negative, meaning that the difference from placebo was not significant. That was for citalopram, for restricted and repetitive behaviors. Activation and other side effects were common. And the same with fluoxetine, negative studies for repetitive behaviors and other behaviors in youth. That's 2 different studies. And then fluvoxamine, interestingly, was found to benefit adults with autism spectrum disorders by Chris McDougall in 1996 in a small study. I have had personally better luck with other medications than fluvoxamine, just as a caveat. Okay, and then atomoxetine, as I told you, there's some interesting hint that atomoxetine can improve inhibitory control as part of executive functions on a stop signal task. And that also helped in adults without ADHD in a study by Chamberlain in 2007, and possibly improved restricted and repetitive behaviors in ASD in a study by Hafterkamp in Holland. The clinical caveat is that it can be useful even in severe disabilities and in adults, but you do need to start low and go slow. Okay, so what medications warrant further studying in autism spectrum disorders? Atomoxetine, as we just said, for impulsive aggression, including in adults with autism spectrum disorders. And dextroamphetamine, immediate release for all ages. In my experience, it causes the least irritability and appetite suppression. But of course, you need the controlled trials. And then amitriptyline, we talked about the 50-patient case series. And so really what happens with patients is that for restricted and repetitive behaviors, the psychiatrist has no more medications on the menu. And you have your back against the wall and the parents are in dire straits, and you really need something for treatment resistance. And so amitriptyline can be useful in that scenario if you're careful. Okay, and then loxapine is another, it's an older antipsychotic that in low doses of 5 to 10 milligrams per day clinically, well, on PET studies, it actually resembles an atypical antipsychotic, but it appears more weight neutral than the atypical antipsychotics. But we have to show that doing a randomized control trial. Okay, so this is the study. I'm going to give you a few details about the study that I've planned for amitriptyline that we hope will be starting in March, if we can get all the pieces together for this investigator-initiated trial. And it's sponsored by internal funding at UMKC. So children and adolescents aged 6 to 17 with ASD, at least moderate repetitive behaviors, mild intellectual disability, or higher functioning. And they can be stable on anti-seizure medications. So 30 subjects will be randomized to amitriptyline or placebo in lookalike capsules. And it's a 10-week acute study, parallel design, double-blinded. The rating scales, there'll be various rating scales, including the CY box, and then the vital signs, blood tests, EKGs, eye movement tracking, and we plan to check brain-derived neurotrophic factor at baseline and end in peripheral white blood cells as an indicator of neurotrophic activity. And females of childbearing age have got to have a beta HCG blood test first to confirm that they're not pregnant. But the study inclusion criteria are males and females, 6 to 17, autism spectrum disorder validated on the ADIR, significant repetitive behaviors on the child Y box PDD version, and mild intellectual disability or higher functioning. So study exclusion criteria will be absence of a reliable caregiver, allergy to amitriptyline, previous neuroleptic malignant syndrome, seizures in the past 3 months, bipolar mood disorder confirmed or psychosis past or present, unstable medical illness, other psychotropic medications, just apart from lorazepam as a PRN once a day. And then QTC, as we said, if it's more than 440 or the child is non-compliant with an EKG, even after a milligram of risperidone and a milligram of alprazolam together an hour before and repeated at the time if needed. Okay, so multimodal treatment in all cases is best. So functional behavior analysis and applied behavior analysis, as described by Ava Lovas, is the only known treatment to improve core ASD features. So if a child or adolescent is on this and they want to be in the study, they can. We just need it to be kept constant during the study. And they will continue any interventions at school that they've been getting, but just not introduce new interventions while they're in the study. Okay, so conclusions and teaching points. So there is no known medication as yet shown to treat restricted and repetitive behaviors in autism spectrum disorders. SSRIs so far are not effective for this in studies in children and adolescents. Amitriptyline is a tricyclic antidepressant commonly used in pediatric practice for functional abdominal pain, chronic pain, and migraine. And preliminary clinical experience suggests its efficacy in low dose for repetitive behaviors in autism spectrum disorders, but controlled trials are needed. So in our experience, it may also benefit sleep, ADHD, anxiety, and enuresis. So I have a clinical trial, hopefully starting in March, of amitriptyline for repetitive behaviors in children and adolescents with autism and mild or no intellectual disability. And I just wanted to tell everybody, thank you very much for attending. And also, there is a series of 9 autism teaching videos. So myself and some colleagues that are on the training subcommittee of the Autism Committee of AACAP developed these 9 teaching videos for training directors and others to use. So all you have to do is you Google, you just type in AACAP autism teaching videos, and it'll pull up these 9 videos, and it spans like successful assessment, successful office visits, what are the criteria for autism, what are the criteria for intellectual disability, how do you do a genetic workup, how do you help transitional age folks, how do you help with education, and lots of different topics that are really of interest that we're hoping that training directors and others can use. So for study referrals, I'm going to keep this up as my last slide in case anybody wants to just jot this down for future study referrals. Dr. Muna Telsom is my study coordinator, and that's her phone number and her email address. So thank you very much all, and I just want to find out if anybody has any questions.
So I do. It's not a question, it's a confession. About 30 years ago, when I was at Vanderbilt, I was having trouble with sleeping. And so I went to a physician and he said, here's this thing called Amitriptyline. You take 1 dose of it only, that's all, and see what it does. And I started sleeping great.
Oh, well, that's
No
good
effects,
to know.
no effects of any problems. And at one point then, actually when we moved up here, maybe 5 or 6 years ago, I decided, well, maybe this thing doesn't even matter. I've taken it for 25 years or whatever. It may not be doing anything. So I took myself off of it. And it lasted about a month. I wanted to really see if it was going to change my sleeping behavior, and it did when I took that off. And I just had trouble getting to sleep, and I would tend to wake up more. And boy, once I went back on that amitriptyline, life was great again.
Okay, that's wonderful to know. Hopefully that was also good for your brain as well.
I hope it was. I can't vouch for that.
That's why you're so brainy. Yeah.
It is like a miracle drug, depending on the doses you use and things like that. It's really remarkable.
Right. Right. I've got some cases that I actually need to write up of young adults with severe developmental disabilities. One in particular had done well on atomoxetine, but her adoptive mother couldn't afford the copay for atomoxetine, and she specifically asked me for amitriptyline, and the girl she's just better able to do so many different things. She's able to make her own appointments now. She's able to catch her transportation on her own without her mother having to take her out and that kind of thing. And so I would really like to be able to demonstrate that it does have a neurotrophic effect as well. But that's part of the reason that I'm doing this, is before I die, I would really like to try and get it on the map, at least so that people can refer back when their back's up against the wall and say, here's something we could try. Okay, you have to be careful. You've got to monitor your EKG and your blood levels, but this could really help. So I have talked to clinicians around the country as well and said, have you ever heard of using amitriptyline in autism? And they're like, I use it all the time, especially for repetitive behaviors, which is crazy, really, because nothing much is written about it anyway. Nothing's really published about it, So, yeah, but that challenge is, to be able to demonstrate it in a placebo-controlled trial. But interestingly, it is used in children a lot for pain, for functional abdominal pain by gastroenterologists. So so that's great. Yeah, it's an old drug. So you know what, with all the new drugs that we've developed and all the high hopes, and the oxytocin that was going to cure autism has not happened so far. So I know there's a study of flavonoids now targeting core features of autism. You know, like flavonoids are in colorful fruits. They're kind of supposed to benefit your brain and that kind of thing. So if you look on clinicaltrials.gov, there's a study of flavonoids for core features of autism. So, but that's about it. I mean, there's not much. You know, what people do is they put on antipsychotics and they just keep increasing the dose until, I mean, I shouldn't say that, but high dose antipsychotics are not going to do it. But in my experience, a non-stimulant ADHD medication may be the answer. Okay, I'll stop going off now. Does anybody else have questions?
I do. Thank you for a really nice talk. That was a wonderful, I think, background of some of the pharmacological studies that have been done in ASD. I'm Catherine Underwood with Matt Mosconi, and I'm really interested in actually how inhibitory control processes are related to repetitive behaviors in autism and trying to find better ways of measuring those. So I'm really interested in your upcoming study, what you're using for your outcome measures. So are you going to be using the CY box as a measure of repetitive behavior, but then also, I know you mentioned that you had an eye tracking component, and I think, you know, something that I think about a lot with some of the tasks that I'm developing are how we have all of these randomized control trials, but we just don't have very good outcome measures to really be able to capture change very well, or to be able to parse apart between individuals. And so I'm curious if you have insight into how we can do that better, and if there are ways you're tackling that in your study.
Well, that is the big challenge. That's the huge challenge, is to clearly capture what if any change occurs, you know. So the big bugbear in placebo-controlled trials is that there is a certain amount of placebo response that the parents feel like automatically they have this whole team helping them now. So the tension is released. I mean, it's relieved quite significantly, and they start taking the pressure off their child as well. It's like, he's in a study, we're going to see if the drug works. So they stop setting so many limits and making demands and that kind of stuff. They're like, everything's going to be okay. So the whole mindset can be a problem. And there's been a lot of talk about how to try to minimize the placebo response. So one of the strategies is to not see them as frequently towards the end of the trial, and not have them fill out questionnaires as frequently. So for example, if they're filling out questionnaires every week, the whole thing just becomes a bit of a blur. So I noticed on Chris McDougall's positive fluvoxamine study, they only had people fill out questionnaires every 4 weeks, and they didn't have the visits as frequently towards the end. So there is, I mean, it's still the same old stuff. I've modeled my study on Brian King's citalopram study for repetitive behaviors. And so his main outcome measures were the clinical global impressions, which is just a very kind of subjective rating scale, like, is this person better or are they not, you know? And that might just be the 5 minutes that you're seeing them in. So so there's that, the clinical global impressions, and the CY box, certain subscales of the CY box, and then also the restricted and repetitive behavior scale, the RRBS, and then also the aberrant behavior checklist irritability subscale, just for what that's worth. and an ADHD rating scale. So yeah, the big question is, are these people going to become activated? You know, because a lot of times, I mean, in this chart review, I was using risperidone together with the amitriptyline, and so risperidone is kind of the other component. But I'm always thinking, if I see too many people become activated at the start of the trial, I will put an amendment into the IRB that if they become too activated, we can use risperidone to try and dampen down the activation component. So whatever, but I'm proud of you for studying this field.
That was a helpful answer. Thank you.
Fun. You know, when I did a randomized control trial of valproate for regression in youth with autism, and I was on the phone to my mentors every day. I mean, there were so many issues that came up. It was just almost unbelievable. And but credit to my mentors, they walked me through it. They were like, "This is not a problem." So clinical trials are a special challenge for sure. I know Maggie is also doing clinical trials with Dr. Mosconi. So yeah. Any other questions? Any comments or anything like that? Okay, well, thank you so much.
Thank you.
I was just going to say, we're just at time, so thank you all for joining us, and thank you, Dr. Hellings, for a great talk.
Yeah, very good.
Thank you so much. Thanks all, and thanks for inviting me. Take care and send me some study candidates if you can. Thanks. All the best.
Take care.
Okay, thanks. You too. Bye.